All right, hello everybody. Welcome to our second podcast where Dr. Kemple and myself will be speaking about respiratory issues. I asked all of our paramedic students to submit some questions, and that's what we're going to be going over. Again, my name is Matt Phillips. I'm the chair of the program and program director for Owens Community College, and across the desk from me is...
Hey, I'm Dr. Kemple. I am the medical director for the Owens Paramedic program. Also do some EMS medical direction locally in Toledo, and I work in the ER as an emergency medicine physician.
All right, great. Well, let's talk about respiration. Like I said, I went to the paramedic class and asked them what were some burning questions in their minds about respiration, and here's kind of what I got. So, Dr. Kemple, the first question is, how exactly do the mechanics of a rescue pod work, and does that do anything for CPAP?
All right, so good question. The first one, let's start with, how does a rescue pod work? The way rescue pod work is it's called a negative impedance threshold device. So it actually reduces the amount of intrathoracic pressure. It reduces volume in the lungs, which will reduce the pressure inside the chest. The reason this is important and why we use it during CPR is because it allows us to get better recoil of the chest, and that negative pressure will help pull blood into the superior and inferior vena cava, preloading the heart, so that will then increase our output for CPR. The second question is, does it improve with the use of CPAP? The answer is generally no. We don't generally use this if somebody's conscious. Most protocols you'll see will actually say, if ROSC is achieved, remove the threshold device. The reason is that in CPAP, it's actually kind of counterintuitive to what we want. In CPAP, we want positive airway pressure. That's continuous positive airway pressure. That's what CPAP means. So if we are pulling air out of the lungs and not maintaining a constant pressure, it'll actually allow those bronchioles to collapse more, and it'll make COPD worse, really.
Oh, okay. All right, so a nugget for the paramedic student is... So, like I said, like a nugget for the students would be then to make sure they take the rescue pod off before they use CPAP, correct?
Absolutely.
Okay,
Yeah.
Great. All right, let's go on to question 2 here. When exactly will you use mag sulfate for its smooth muscle relaxing properties for a case such as asthma, and are there other situations it can be used for?
Yeah, actually, magnesium's kind of a pretty versatile medication in the ER. Absolutely, respiratory, it does have some smooth muscle relaxing properties, which is what we use it for in asthma. Not generally seen in COPD. COPD, it's a lot more inflammation due to mucus production, and the cilia, the little hairs not clearing the airways well, and reduced lung compliance. So the lungs don't rebound as well as they would. So MAG is not going to help that. But in asthma, where it's actually a bronchoconstriction issue, magnesium is helpful for that. So if the patient just looks sick, in the ER, if I see somebody says, oh, I'm having an asthma attack while they're playing on their cell phone, then I'm probably just going to do a couple treatments, maybe some steroids. If somebody's working to breathe and I'm anticipating that I may need to do more, they may need admitted, I'll usually go right ahead and just order the magnesium sulfate as one more adjunct. Some other things we use it for is migraines. It's been shown to be helpful for migraine treatment. Additionally, I will use it for preeclampsia and eclampsia, so in premature contractions, relaxing that uterus and relaxing the blood vessels with muscle to help reduce blood pressure. It's been shown very helpful with that. But again, remember, magnesium is not completely benign. One of the things you have to watch out for is if we give too much magnesium sulfate, they could actually suppress the respiratory drive. So that's something to watch for, especially if you're doing any interfacility transports while someone's getting a lot of magnesium for eclampsia or preeclampsia.
Okay. All right, it makes a lot of sense. Thank you. All right, moving on. Our third question here. Let's see here. Can you explain the process of transportation of CO2 after cells produce it, and how does it get back to the lungs?
Right. So, as we know, CO2 is a byproduct of respiration. So respiration in a aerobic fashion. We're using oxygen to produce energy for the cells. When CO2 is produced, the cells have to get rid of it. A majority of this happens through diffusion. So that's the natural gradient of the gas going to areas where it's less. We carry a decent amount of CO2 in our plasma. And when we do arterial blood gas, we're actually not measuring red blood cells, the gases on those. We're measuring the gases in the plasma. But the red blood cells will pick up CO2 and turn it into bicarbonate, and it will carry it on the red blood cell till it gets to the lungs where it converts it back to CO2, and we off-gas it that way.
Okay, great. All right, moving on here. How long does it take to knock out a hypoxic drive?
There's no set time. Hypoxic drive is basically when we have somebody who has a history of COPD that's pretty severe. Normal ventilation, which is the amount of respirations per minute, of the body is controlled by levels of carbon dioxide. And we have chemoreceptors in our neck, in our carotids, which will help us with that. If somebody has chronically elevated CO2 levels, such as somebody with COPD, the body gets desensitized to it. And so it starts responding to oxygen levels in the blood as a factor of determining how much to breathe. When the oxygen levels start going down, the patient will breathe more. If the oxygen levels are going up, the patient will breathe less. In terms of COPDers, if we flood them with oxygen, your O2 sat will be okay initially, and in the short term, absolutely give them oxygen if they need it. In the long term, and we're talking usually hours to days, it would take to do this. It's not going to happen over 10 minutes. In hours to days, what you'll start to see is those O2 receptors will say, hey, we have a lot of oxygen, we're going to slow down our respirations. Problem is, that's going to raise CO2 levels because we're not off-gassing CO2, which will make people more sleepy, breathe less in the end, and then you can have respiratory failure that way. But anybody who's sick enough to have hypoxic drive issue and is getting oxygen supplementally on top of what their normal is should probably be on a BiPAP or a CPAP anyway. And I generally would not see that as being a huge deal. Absolutely for EMS, unless you're working out in Alaska with a 6-hour transport time, I would not expect an hour, hour and a half, 2-hour transfer to have any issues with hypoxic drive.
Perfect. Okay. Here's one about ventilators, and one of the students asked, what indicators might you look for if a patient is prone to becoming reliant on a ventilator?
Well, one of the first things you can look for is, do they have a trach scar? Have they been trached before? The other thing that's really great is I ask them, have you ever needed to be intubated for this disease before? Have you ever been in the ICU for this disease before? If they say yes, that means they're higher risk. They're more likely that they could need to be on a ventilator. But eventually in EMS, especially if you're working one area long enough, you start to learn who the people are. You know, who's got the severe COPD, who's got asthma, you know, that kind of thing, who's got CHF. So that will give you a better indication. You'll say, man, we had to tube them last time, or they tubed them when they got to the ER, or we took them out of the ICU 3 or 4 times to Regency or something like that. So those are things that you'll learn just partly on the job, but ask the patient. The patient's your best resource if they can answer.
Patients tell me that last time I was this bad, they had to intubate me.
Absolutely.
That's when you need to be getting your stuff around. So here's one that kind of goes back a little bit to our last podcast, and the question was, have you heard about the new nasal cannula that can go up to 60 liters per minute?
Yeah, so this is called a high-flow nasal cannula. We've actually been using these for years. They're not super new, but we use it a lot actually for pediatric bronchiolitis. It's been used for years in that instance. The reason it's good is because it creates a strong enough current of oxygen that you're getting gas exchange even without a significant ventilation, without moving a ton of air. So remember, when we breathe, we've got to move dead space air, we got to move air in and out of the lungs, and that's getting us our gas exchange. A high flow nasal cannula going 60 liters per minute has enough pressure that it's getting oxygen down into the lungs. Not a ton, but it's getting more. And what that ultimately does is, especially for the bronchiolitis kids who are breathing 50, 60, 70 times a minute, is it reduces their work of breathing without putting them on a mask such as a BiPAP or a CPAP. And so that's mostly actually what we use it for. We do use it weaning people off of a BiPAP, more for like a CHF as opposed to a COPD. Remember, COPD, the problem is that they're not off-gassing CO2, and we don't want them retaining CO2. But CHF, pneumonia, they're not getting oxygen, and they're having increased work of breathing. If we can keep them off of a mask, it's much more comfortable just to have a nasal cannula. You're able to eat and drink. You can walk to the bathroom. If you're on that mask for a BiPAP, you have a Foley. You can't eat and drink, just sips of water. So it's a lot less comfortable, and it's a lot better for quality of life. People are ambulating sooner, less blood clots. It's definitely a good way to go.
All right, next one is brachiothoroplasty has a considerable success rate in reducing emergency room visits for asthma attacks. Why is it not a preferred treatment for patients who have had multiple visits within a year to the ER with complaints of asthmatic exacerbation? That's easy for me.
Exacerbation.
Yeah,
I got you.
I've always got that hard with that question.
So first, let's start with what is bronchothermoplasty, because I'm sure most people probably aren't too familiar with it. And honestly, before this question, I wasn't too familiar with it. Ultimately, it's radiofrequency ablation. It's similar to what we do in a uterus for fibroids, where we ablate the muscle to diminish the muscle size, diminish the blood flow a little bit, thus we would get less bleeding. Well, in the bronchioles, we can do that to reduce the amount of smooth muscle. It's a much more smaller dose, much more controlled, but we can reduce the smooth muscle, and thus people's asthma theoretically will be less pronounced when they do have chronic asthma and constriction from that. Now, I was doing some research. The 5-year safety, it was only FDA approved in 2010. The 5-year safety seems to be pretty strong, that there's no major adverse events after 1, 2, 3, 4, 5 years after the procedure. It does have a significant decrease, especially in the first year after the immediate post-procedure effects of increased problems, but it does have decreased visits to the ER up to 84% in some populations. So that looks good. The one thing that I noted is the functional expiratory volume, which is really an asthmatic's problem, how much can they breathe out, was relatively unchanged. There were slightly fewer ER visits, but from what I could see, the amount of hospitalizations did not change. So it requires less medications, less rescue inhaler doses, less steroids. It ultimately doesn't change the long-term course of severity of disease in that aspect. It has a place, I'm sure. I'm not a pulmonologist, a lung doctor, so I can't tell you for sure exactly who qualifies. Ultimately, people are on long-acting steroids, long-acting beta blockers for the beta 2. Beta agonists. Those people who are failing those are more likely to get it. But it doesn't seem like it actually reduces the significant episodes. You're still going to get hospitalized the same amount. It doesn't reduce that severity. Your daily quality of life is better. Why is it not more mainstream? I'm going to guess it's about the almighty dollar, which is what most things in medicine are about. It's new, it's patented, it's not yet open for generics. So, and then the other thing is you have to train people to do it. You have to get people on board, you have to get pulmonologists to train, feel comfortable doing it in their training, and that takes time. So, a pulmonology residency is 3 years. So people, when it was FDA approved in 2010, if their hospital's on the cutting edge and started it while they were there, they probably got 2 or 3 years left. Just graduated 2012-13, but in realistically, it's going to be probably a few more years till it's more mainstream. And even then, if it's not reducing hospitalizations, is it really worth it? That's the question. Now, the ER visits, yes, but hospitalizations, which are the more severe ones, that's a question I can't answer, unfortunately, but I bet that's something people are thinking about.
Oh, most definitely. Probably have to get all the insurance companies on board with it too. So, all right. What is your opinion on peak flow measurements? Are they accurate, and are they underutilized?
I love peak flow. They are definitely underutilized, and really any asthma protocol in a hospital actually includes it. So what is peak flow? Peak flow is basically an FEV, a forced expiratory volume. We ask somebody to take a deep breath, blow out as hard as they can like a birthday candle, and we see what volume of air they're able to expire. This is great pre and post treatment of asthmatics because we can get a peak flow if they can tolerate it before. Some people are just too sick, too short of breath that I'm not going to stick that in their mouth and ask them to blow into it when they can't breathe to begin with. But you can see, hey, they were only getting 150, 200 mLs, and now they're getting 3, 4, 500. That's a big difference in the peak flow. So they are underused. They are accurate to the point of they're as good as your patient. If your patient puts in a good effort, they're accurate. If your patient's not putting in a good effort, it's not going to be accurate. I did have one other question about eosinophilic asthma. I just wanted to touch base on that one real quick. So eosinophilic asthma, and this kind of ties into the asthma that we were talking about. Basically, a large percentage of people with asthma is actually caused by eosinophils, one of our white blood cells. They produce something called cytokines. Cytokines create inflammation, and that can create bronchoconstriction. So the question was, why isn't there more research devoted to this? Why aren't there other treatment options for it? Well, I was doing some research on that as well, and it looks like there are. Actually, in July of last year, 2 new medications came out, reslizumab and mepolizumab. So anything that ends in MAB, M-A-B, means monoclonal antibody. So it's an antibody that was created to bind something and block it. In terms of eosinophils, their cell line is differentiated. What I mean by that is the stem cells get told to become eosinophils by something called interleukin 5, IL-5. That also is responsible for some of the activation of eosinophils, which would then produce the cytokines which produce inflammation, which cause asthma attacks. By binding to the IL-5 receptors, we're creating less eosinophils and we're not allowing them to activate as much. That's the goal. Now, these medications, while they're there, they have to be dosed every 4 weeks. The first one is IV. The other one can be done sub-Q. It requires about 3 vials for the average person per dose. The cheapest one's $1,000 a vial. The other one's $3,000 a vial. So again, price. Insurance companies, if they can control you with steroids, broncho inhalers, that kind of thing, it is actually cheaper for them to let you go to the ER and get a $1,000 visit for a couple treatments than it is for them to spend $9,000 every 4 weeks on a treatment. Wow. So it's about the money.
All right, a couple more questions we have for you, Dr. Kemple. In the pre-hospital setting, we always try to control a patient's rate when dealing with AFib or A-flutter. What is the research saying? Is that really best practice?
So ultimately, no, is the short answer. The longer answer is it depends on what's causing the increased rate. So if somebody is truly just atrial fibrillation with rapid ventricular response and their rate is elevated, then controlling the rate is indicated as a first step. But what we have been finding is a majority or a large portion of our AFib RVR patients have an underlying cause, whether it be sepsis or CHF are the 2 big ones. So studies have shown that the quicker you rate control a sepsis or CHF patient, the higher the mortality is. So what we're finding is in myself or you, Matt, or our average student, if they get sick with sepsis or a breathing problem, they're going to get tachycardic, sinus tachycardia. Their heart rate will elevate 120, 130, maybe even 140, depending on the severity. You take an atrial fibrillation person with a heart rate of 140. Well, because it's in AFib, we say, oh, it's AFib RVR, we need to rate control. Would we rate control a sinus tach of 140 who's septic? No, we treat the underlying cause. So what the studies have shown is treating the underlying cause, delaying that rate control, at least temporarily if we can, is the best thing we can do for our patients. We have much less risk of intubations, CPR, vasopressors, all those kinds of things. Now, that being said, if your patient is truly unstable, then you do Edison's medicine. You're going to be cardioverting them anyway. But if you think you have a little bit of time, if they have a fever, if they're complaining of cough, sepsis-type symptoms, I would say fluids would be where I would start. Let's treat the underlying cause. If they're not truly unstable, you have some time to get them to the ER. Just because we can treat something doesn't mean we have to.
Makes sense to me. All right. Back to CPAP a little bit. Does transport times limit us in the pre-hospital settings when we should be using CPAP? Should we stay and play a little bit more, or should we just get them in the truck and transport them, or should we work on how should we do that?
Right. So I've heard some people say that, well, we were 5 minutes around from the corner, of the hospital, and it's short transport, so we didn't bother putting them on a CPAP. But the truth is that even a short course of CPAP is actually helpful. There is no time frame in which we'd say it's just too short of a time frame, we don't need to do CPAP. If it's indicated clinically that they would benefit from it at some point, go ahead and put them on it. Much rather you put somebody on a CPAP and them not need it than need it and not put them on. And the studies have shown that. There was a recent study from American Journal of Emergency Medicine that was in 2017, which showed that patients had a better outcome if we did it shorter, even if it was a short transport time.
All right. A little bit about sepsis here. And is it really important for us pre-hospital providers to be able to recognize sepsis and to be able to trigger a sepsis alert with the hospital?
So this is a two-part question. Part one, is it important the pre-hospital provider to be able to recognize sepsis? Absolutely. Yes, you need to have a good idea of what's going on because these people are generally going to be fluid depleted, and one of the best things you can do is give them fluids, especially if they're getting hypotensive, even if they have CHF history or heart failure or renal disease. They need those fluids. They need to get their tank filled. We can worry about moving the fluid out of the lungs later if we have to. Now, are sepsis alerts and triggers really necessary? That's the second part of this question. Lucas County has a sepsis alert system. Perrysburg's adding it in, as far as I understand. But the literature doesn't show a significant improvement. Not only does the literature not show that actually starting the fluids in the ambulance changes the overall morbidity and mortality, but starting antibiotics in the ambulance has not been shown to actually shorten the course of the disease. I think a big part of this is just transport times are low. You're not with them long enough that your interventions are making as big of a difference in the long scheme of things. But in the immediate, I absolutely think it's appropriate and it's necessary for you to know to recognize sepsis, start those fluids, especially if they're hypotensive, because these studies don't get every subset of patient. They just take, did they meet the criteria for the study or not? If you take the sickest of the sick, I guarantee you that EMS interventions are going to help. But it might not decrease the overall hospital stay time. So take it with a grain of salt. I do not think sepsis alerts are necessary. I don't think starting antibiotics in an ambulance is necessary. I do think fluid management and recognizing sepsis is necessary.
Okay. Well, along with that, then how much fluid is enough? How much is too much? How do we gauge that within our short transport times to make sure the patient gets what they need, but not too much?
Yeah, so CMS, which is Center for Medicare Services, which basically creates all of the best practices, says 30 mLs per kg is a acceptable fluid bolus for a hypotensive septic patient. If they fail after that, you go to vasopressors. So in a squad, in your transport time, I very much doubt you're going to be able to get 30 mLs per kg in somebody. Generally, it's going to take about an hour or two to do that, generally, especially if you have one line. If you have two big 16-gauge IVs, yeah, you can pump them full fluids pretty quick. But it's not necessary. Get a liter, hang it wide open, and that's about what you need to do. If they're really hypotensive, get a second line, start a second liter at the same time. But 30 milliliters per kilogram is ultimately the goal. But I will say when it comes to these sepsis best care practices, these are things that they've found, but there's actually not a ton of literature to say that 30 mLs per kg is the right dose. We don't know what the right dose is. We just know that we try them with fluids first. If they're not responding, and I can tell you, if somebody's got a blood pressure of 60 and I give them a liter and it's still 60 and it hasn't changed at all, I'm going to start them on pressors before I finish my 30 mLs. So it's all about treating the patient, not treating the machine, not following a set protocol, so to speak. Don't do cookbook medicine. Look at your patient, evaluate your patient, and do what you think is best for them within the confines of your protocol.
It's all some great answers, and I'm sure the students will learn a lot from it. And one of the takeaways is, I think you hit the nail on the head in your last sentence there, is treat your patient. All right, don't always be looking at all your cool gadgets and everything. Do what's best for your patient, keep an eye on them, and go from there.
Absolutely. Treat the patient, not the machine.
Well, I think that concludes our second podcast. We hope you all enjoy that. And for Dr. Kemple and myself, we appreciate you listening. And until next time.
Absolutely. Thank you guys for listening, and hope you have a good holiday.